This talk is about the Parks-Bielschowsky three-step test. Initially, we will describe the mechanics of this test and the principles behind its effectiveness. And in the second section, we will go through an example that I hope will answer any lingering questions about the Parks-Bielschowsky three-step test. This figure highlights the 3 steps involved in this test. The aim of these steps is to detect the muscle under action, producing vertical misalignment in patients with single muscle defects. Vertical misalignment can be caused by weakness of 4 muscles in each eye. After the first step, we are left with the possibility of 2 weak muscles in each eye. After the second step, we are then left with the possibility of 1 weak muscle in each eye. And after the third step, we get to determine the eye involved, hence the single weak muscle affected. I will now proceed to tell you about each of the steps. The first step consists of determining which eye is higher deviated in primary position, that is, the hypertropic eye. The second step consists of determining if the vertical deviation is greater in right gaze or left gaze. The third step consists of determining if the vertical deviation is greater with right head tilt or left head tilt. It is worthwhile for us to understand why the Parks-Bielschowsky three-step test is effective in the right setting to dust off a few key points about extraocular movements, especially about vertical alignment. In primary position, vertical alignment is kept by the opposing forces generated at each eye by the contraction of the elevators and depressors. The elevators are the superior recti and the inferior oblique. The depressors are the inferior recti and the superior obliques. During right gaze, the vertical position of the right eye is maintained by the opposing forces generated by the contraction of the right superior rectus and the right inferior rectus, whereas the vertical position of the left eye is maintained by the opposing forces generated by the contraction of the left inferior oblique and left superior oblique. During left gaze, the vertical position of the right eye is maintained by the interaction of the opposing forces generated by the contraction of the right inferior oblique and the right superior oblique, whereas the vertical position of the left eye is maintained by the interaction of the opposing forces generated by the contraction of the left superior rectus and inferior rectus. During right head tilt, the vertical position of the right eye is maintained by the balance of vertical forces generated by the contraction of the extorting muscle, the right inferior oblique and the right inferior rectus, and in the left eye by the balance of the vertical forces generated by the contraction of the intorting muscle, the left superior rectus and left superior oblique. During left head tilt, the vertical position of the right eye is maintained by the balance of the vertical forces generated by the contraction of the intorting muscles, the superior rectus and the superior oblique. The vertical position of the left eye by the balance of the vertical forces generated by the extorting muscles, the left inferior oblique and left inferior rectus. This table summarizes the forces that maintain vertical position in each eye during different gazes and during head tilt. When I started using the Parks-Bielschowsky three-step test, it was especially difficult for me to grasp the contribution of extorters and intorters to vertical positioning during head tilt. If you have a similar issue, stop the video and go over this table. Otherwise, we will continue with an example. As you recall, the first step in the PB three-step test consists of observing the eyes in primary position, and what this accomplishes is to decrease the number of possible underactive muscles from 4 to 2 muscles in each eye. In this frame, on the right side, I have represented a patient with a hyper-deviated right eye compared to the left, or simply stated with right eye hypertropia. And on the other side, a patient with left hypertropia. In this frame, I have introduced 2 buttons to select one, depending on the patient's finding. Let's say we see a patient with left hypertropia in primary position and go on to press the corresponding button to learn about the muscle involved in this situation and ultimately to eliminate 2 muscles in each eye as possible culprits. As you can see at the top half of this frame, I have introduced the right and the left eyes with green arrows indicating the actions of the different extraocular muscles. Notice that unlike the medial rectus and the lateral rectus that only have 1 arrow, the other extraocular muscles have 2 arrows. This is so because in addition to their vertical action, I am representing their intorting and extorting actions. In this frame, I will indicate the muscles producing left hypertropia by changing the color of the arrows to yellow. As you can see, left hypertropia is either the result of the underaction of the ipsilateral eye depressors, the left inferior rectus and the superior oblique, or the underaction of the contralateral eye elevators, the right superior rectus or inferior oblique. So at this point, as expected, we have eliminated 4 extraocular muscles as possible culprit of the left hypertropia: the right inferior rectus, the right superior oblique, the left superior rectus, and the left inferior oblique. Hence, by observation of left hypertropia in primary position, we can surmise that in cases of single muscle underactivity, that either the right superior rectus, the right inferior oblique, the left superior oblique, or the left inferior rectus is producing the left hypertropia. So we have concluded the first step. The second step consists of observing the eyes during right and left lateral gaze. And this step aims at decreasing the number of possible underactive muscles from 2 to 1 in each eye. In this frame, you can see 2 options. Indicated by the arrow is the representation of maximal left hypertropia on right lateral gaze, and on the other side, the representation of maximal left hypertropia on left lateral gaze. In this frame, by the introduction of a button below each possibility, I have given you the misleading impression that you can choose between the 2 options, but this is not the case. I will choose for you, and I am choosing left hypertropia worst on left gaze. During left gaze, the vertical position of the left eye is determined by the interaction of the superior rectus and the inferior rectus. Hence, since the superior oblique does not participate in this action, we can eliminate it as a culprit. And furthermore, since the superior rectus was already eliminated as a culprit of left hypertropia during step 1, we can conclude that in the left eye, the only possible muscle under action producing left hypertropia is the inferior rectus, whereas at the right eye, it is the balance of the contraction of the inferior oblique and superior oblique that determines vertical position. Hence, we can eliminate the superior rectus since the superior rectus is not involved in this action, and also the superior oblique, because although involved in this action, it was already eliminated as a possible culprit during step 1. So the only muscle possibly producing left hypertropia in the right eye is the inferior oblique. After the second step, we take the third and final step. It consists of observing the eye position following right and left head tilt and selecting the muscle under action causing the hypertropia by eliminating the non-affected eye. In this frame, you can see the two options: maximal left hypertropia on right head tilt and on left head tilt. In this frame, I have introduced a button below each possibility. Nevertheless, as last time, I will choose for you. And I am choosing maximal hypertropia on left head tilt. Vertical positioning during left head tilt is achieved in the right eye by the balance of the forces generated by the two extorters, the inferior oblique and the inferior rectus. Since the inferior rectus was eliminated as a culprit before, the only possible option in this eye is the inferior oblique. Vertical positioning during left head tilt is achieved in the left eye by the balance of the forces generated by the intortor, the superior rectus and the superior oblique. But since these two muscles have already been eliminated as culprit, the only other muscle not yet eliminated in this eye is the inferior rectus. Yet, since this muscle is not involved in this action, it can also be eliminated. And the only possible conclusion is that the muscle whose underaction is causing the left hypertropia is the right inferior oblique, as indicated here. Understanding the Parks-Bielschowsky three-step test is hard, but there is an easy way. The Stuart McFarland optometrists have developed a Parks-Bielschowsky three-step test calculator. You can find it at this address. This calculator makes thinking unnecessary when evaluating hypertropia due to single muscle underaction. And just by answering the questions corresponding to each of the previously mentioned steps correctly, you can get the correct answer. Let's say we use the same scenario as we did for our example. If the hyperdeviated eye in primary position is the left eye, the greater vertical elevation is when gazing to the left, and the greater vertical deviation is during left head tilt. The culprit muscle, the right inferior oblique, is selected by the calculator as indicated here. So this being the case, why do we need to learn how to analyze each step of the Parks-Bielschowsky three-step test? The reason is that so far during exams, the Parks-Bielschowsky three-step test calculator is not allowed. Thank you very much for your attention.